Good afternoon, friends. We'll go for a new topic. We have finished Alzheimer's and Parkinsonism recently. We'll go for a new one, that is stroke. And again, before I forget, I'd like to add that please go through your pharmacology and pharmacotherapeutics topics related to drug acting on blood. Particularly all the agents which are acting on various coagulation pathways, anticoagulants with different levels and different types, and other anti-ischemic agents. So please go through it. You have done it earlier. What are these drugs? What are their pros and cons? What are their importances? You please make it have a good review of it. हाँ हाँ गुड आफ्टरनून. बोल बोल काय म्हणतोस?
काय नाही सर, ते रजिस्ट्रेशन MSPचं राहिलं होतं, म्हणजे ते आयडेंटिटी स्लिप राहिली फक्त, मग त्यांची डिस्क्रिप्शन आली,
हां हां.
ते अपलोड करायचं राहिलं, मग ते झालं होतं गुजरातवरून.
कुठे आहे तू सध्या?
मी गुजरातला स्टुडंट.
बरं, आता मी काय मदत करू शकतो?
नाही काहीच नाही सर, मला फक्त इथं हे सांगा की इथं वेगळ्या वेगळ्या साईन करायचे फक्त.
तू काहीच करू नको. तू स्टुडंट सेक्शनकडे हे घेऊन जा.
ओके,
ते तुला गाईड करतील.
ओके चालेल.
काही अडचण आली तर मला भेटते.
ठीक आहे चालेल.
हां
थँक्यू.
करतो सगळं. तुला काही तुझं बहुतेक तू हे पण नाही नेलं आहे युनिव्हर्सिटीचं हे,
हां
ते घेऊन जा माझ्याकडनं. तू हे आधी याला प्रोसेसला टाक.
ठीक आहे सर.
ये नंतर माझ्याकडे. मी एक क्लास घेतो तोपर्यंत.
ओके
हां ये. So what I need is if you please go through this topic related to, because we'll need the basic information about it. Let us go for the topic stroke. What is stroke and how we have different types of stroke. So what is stroke? Stroke is defined by various agencies. Important is it is a neurological deficit of sudden onset with focal rather than a global dysfunction, and in which after adequate investigation symptoms are presumed to be of non-traumatic vascular origin. Now non-traumatic means there is no external injury to it, so that is a non-traumatic. There can be vascular injury which we can see in next, and that is last for more than 24 hours. One more definition, the simplest definition is when the blood supply to the part of brain is suddenly interrupted, or when the blood vessel in the brain burst, which result into, basically both are the reasons, whether it is interrupted or any blood vessel burst, both are result into decreasing the blood supply to the portion of the brain which is distal to it, that is which is next to it, and therefore there will be ischemia of that particular area. Now again, if you remember ischemic heart diseases, it will you can have some mimicking things. Only thing is, there all the symptoms were relevant with the cardiovascular system. Here the symptoms will be relevant with the brain. So it can be a transient ischemic attack, and where neurological deficit of the vascular origin that will last from few minutes to hours, and it will be resolved within 24 hours. That is called as a transient ischemic attack. Just like in heart also, sort of angina we call it as a transient ischemic attack. That may not affect person too much. Here also it may not affect person too much, and therefore it will be lasting for few minutes, and it will be resolving within 24 hours. But the basic problem may not have been cured, and when again some stress is there, some stress in the sense anything which is not conducive for that good environment, that will be there, it can cause a rebound or severe one. We have basically two types of strokes, very popularly we call them as a hemorrhagic stroke and ischemic strokes. You can see the figures. Here suppose this is a branch of mid-cerebral artery, that is the artery which is this is a major artery which is supplying to brain, supplying blood to brain. So here somewhere any artery, small artery that has been burst, that has been that has been torn, and because of that the blood comes out and it leaks into tissue, So, hello, Milin, can somebody call Milin and inform him? And another one is ischemic stroke. In ischemic, there is a clotting, just like again in myocardial infarction, you have seen it, that there is a clot there, there is obstruction, and that obstruction leads to ischemia to the next portion, and that can be very sudden, and it can result into very severe conditions, including death. So this is what ischemic stroke. These are two important varieties. Let us see their subclassification. That is type of stroke. We have seen ischemic is around 85% people, they have ischemic stroke. Hemorrhagic stroke is there in around 15% of the patient, and both are resulting into what various conditions. So what are the conditions? Hemorrhagic will cause intraparenchymal subarachnoid space will be there, in that the hemorrhage will be there. While in this ischemic, there are various reasons can be there. It may be because of atherosclerosis. Now again, you can imagine, now if the atherosclerosis is one of the reason, then and if it is understood that it is a reason, then again here similar practices are there. Similarly, just like you might have seen this angioplasty over there, similar angioplasties can be made up to brain if it is not very deep, because branching is too much in brain. So if possible, it is done. Stenting can also be done. Again, it will depend on the conditions. Then so if it is atherosclerosis, then we know that plaque is formed. Plaque can cause reduction in the blood supply, and we know various anti-atherosclerosic treatments. So I'll need this assignment. I'll need to know that how many of you remember it. What are the treatments for various atherosclerosis or atherosclerotic diseases? Okay. So for blood, drug acting on blood clotting, wherever they are there, or all the drugs which are acting on blood, because again hemorrhage, we know hemorrhage, again we need drugs which are acting on blood. Then second thing is there, that is called as a penetrating artery disease. It is around in 25% people. That is it is also called as a lacunar type of ischemic stroke. Then next is cardioembolic. Those who have studied arrhythmias earlier, in arrhythmias you might have seen that the arrhythmias of atria, that is atrial fibrillation or atrial flutters, they are responsible for stroke. Okay. This was one of the question I used to ask. This is again, you take it as assignment. This is third assignment I am giving. First one I gave is various drug which are acting on blood. Second I gave on treatment for atherosclerosis, pharmacological treatment for atherosclerosis. Third I am giving you is what is the reason between arrhythmias, particularly atrial arrhythmias and stroke. Okay. This is not a very big one, but I hope you will just go through it. Then third type is a cryptogenic, that means of which origin cannot be understood. Crypto is almost suspense type, or which cannot be resolved, which cannot be identified. So it can be cryptogenic, it can be around in 30%, and it can be because of some unusual cause. Very few of these are actually, that is around 5% overall, that is because of the prothrombotic or prothrombotic dissection, arteriitis, that is inflammation of arteries, migraine, drug abuse, etc. This can be reasons in some of the patients. and this will cause this overall this whole mix of that will contribute to around 5% of stroke cases. So what is the problem? Why? Because it is a major global public health concern, particularly in adults. It is very well, particularly in people having age more than 60, and as the age progresses, the chances of stroke also increases. The second commonest cause of death, particularly in adults, 50% are dependent daily activities. Among the top 4 causes of death in Asian countries is a stroke. In Malaysia, it is 4th common cause of death after septicemia, heart diseases and cancer. So these are various reasons why it is causing stroke. What are the pathways, how we can do it? Fortunately, because of advent of various treatments, various informations, stroke is preventable nowadays. It can be prevented once it is diagnosed earlier. Example, we have seen that just like angina, if you remember, I am just trying repeatedly to make you aware that we are just trying to compare it with angina. In angina also, whenever there was an anginal attack, whenever the person has got for any kind of diagnosis, maybe ECG or whatsoever it may be, then once it is understood, then people can go for treatment, means they go for a prophylactic treatment so that the angina will not progress or it will not be converted into myocardial infarction. This is what you might have studied in your second year pharmacology on therapeutics. So same thing is applying over here. Once it was a transient ischemic attack, once it was understood that the person has faced it, then person can get it diagnosed, and during diagnosis, once it is understood that this is one or other kind of chances are there that the person it can progress into one or other kind of such problem, then we can prevent it. And even if it has occurred, particularly if it is a transient one, it can treat it, but if it is very severe one, then it becomes very difficult to treat or regain the same status, or prognosis is not good. The reason is again there is a big difference as compared to heart. Even after ischemia, although the chances are less, but yes, even after very severe ischemic attack in the heart, some of the person can go beyond 5 years or 10 years, they can survive. However, with this, if the damage is too much, although it is also treatable, but the biggest problem is once the neurons are damaged, then they cannot be regained, and then the person may lose most of the activities. And if the activities are lost, then it becomes gradual loss, and slowly there can be loss of neurons and loss of various activities. So only thing is you can just prolong it, you can just delay it because of that treatment. However, if it is in a very preliminary state, very new one, and it has not reached to more areas, then definitely one can regain it. It can be totally regained, and the person can be almost normal, as we have seen in heart condition. If it is angina, then the person can have a normal life. So stroke is also preventable and treatable disease. More effective if evidence-based primary and secondary prevention strategies are available, and that can be given, that can be guided to the patient. Evidence of intervention that are effective soon after the onset of symptoms are there, and accordingly one can go for various intervention. I told you to go through these various treatment chances, because treatment we know that if it is atherosclerosis, the same treatment for atherosclerosis we are going to give. If we know that it is related to coagulation of blood, then anticoagulant treatment we can have. But only we want to know that what are the pros and cons, that I will have discussion with you people. Understanding the care processes that contribute to the better outcome is there, and accordingly we can improve the care. So we should have various evidence based informations, so that what treatment we can go for ischemic stroke in adults. If it is transient ischemic attack, what we can do. If it is hemorrhagic stroke, what we can do. If it is stroke in children or aneurysmal rupture is there, then what we can do. Okay. and if there is a bleeding is occurring at this brain areas, then what we can do. So we have various ways we can do. Now primary prevention is there, we try to prevent it, but if it is not there, then still there is a situation, then we have to go for acute care, particularly the patient either come from as an outpatient or it is admitted into emergency room, and from that this emergency room we have to go for acute care. After acute care, if the patient is survive, we have got it recovered from the problem, then some of the activities are lost, and if it is they are lost, then we have to give the training so that it can be rehabilitated, sort of training in that particularly in condition where all the functionalities are not possible. Then community reintegration, you guide the people who are taking care of these people, and simultaneously go for secondary prevention. So this is what a brief algorithm we can have for the stroke. So what will happen? We have seen that acute care pathway is there. Accordingly, we can have different type of treatment for different condition. If it is a transient ischemic attack, again we have to give the anti-ischemic treatment, whatsoever it may be. You know again what is anti-ischemic treatment. You have studied it through various ways in myocardial infarction, in angina pectoris, and in blood chapter you have seen various such drugs which can be used in ischemic attacks. Stroke, that is whenever stroke is there, then go for thrombolysis in emergency room or to intensive care unit. So accordingly you have to take care about it. You can have stroke unit care also in hospitals, so that they are equipped with all the things which are required for stroke treatment. Neurointervention in the stroke pathways, so that you can have the minimal damage to the neurons and maximal recovery, and surgery if required in these patients. So these are various conditions done in stroke conditions. Let us have various algorithms for that, particularly for transient ischemic attack. When there is a suspected transient ischemic attack, I told you transient means lasting around 24 hours or so. Sometime it can come back, sometime it will remain as such, but whenever it is there, then it has to be judged. Immediately the blood sugar level should be checked, because if there is a hypoglycemia, then in that people also, or even hypovolemia or hypotension. So these are various shock conditions. So this can also result, or they can also show this kind of condition. So it has to be excluded immediately. These three testing should be done. Then take the history and take this blood sugar level, which is more important. And if it is there, then check three important signs. That is what is the facial activity, that is what the face shows, whether a person can smile or not, whether has its mouth or eye drooped, means it is droop means the muscles has relaxed too much, and therefore it is showing a sort of bend towards downside. So whether it is drooped, whether there is a weakness in the arm, can the person raise both arm or even both extremities, we can say. We call it as a paralysis like sign initially. Can the person speak clearly and understand what you say? So these are three important signs. We call it as a F, A, S, and T means go for all these three signs. That is, test all these three signs. So this fast is there. So if it shows fast is positive, that means yes, there is a problem in the face, there is a problem in the arm or extremities, and there is a problem in the this what we can say speech. Then if it is negative, then still there are chances of transient ischemic attacks, but try for further diagnosis. We call it as a differential diagnosis. So try for differential diagnosis, But if it is very clearly it is their indication, then we call it as a rosier. That is, rosier means recognition of stroke in the uh, emergency room. So in emergency room, the person is admitted, and then it is gives a sign of stroke, or we can say that it is a sign. Then give the treatment for that, for the transient ischemic attack. So there are two chances: it is completely resolved or it is not resolved. If it is not resolved, then go for stroke pathway. We shall see the details about that. If it is resolved, then the person is having even further risk of stroke. Then we have got another pathways. Go for checking various signs, like we call it as a diagnostic scale we have for this, that is ABCD 2. Okay, I'll go for that. We'll discuss this. That is A for age, B for this blood related, okay, diabetes, etc. All these things are there. So we'll check it. If it is, this shows it is less than 4 or more than 4. If it is more than 4, then start aspirin immediately. Admit the person in stroke unit for specialist and start investigation and go for the treatment for that. Then go for brain imaging with MRI and various scanning tests. But if there is a less than 4, then still aspirin and let the person go home. But you can ask the specialist to check it and have the investigation in that week. In that condition, if it is so, then go for brain again, MRI, go for carotid imaging in the patients, and if the patient is candidate for carotid intervention, check it. If it is no, then go for the best medical treatment, like control of blood pressure, B for blood pressure, okay. Antiplatelet drug and cholesterol lowering drugs can be given, and the lifestyle changes, smoking cessation, etc., etc., all can be done, so that this we can bring it less than or lesser score for there in ABCD. If everything shows candidate for carotid intervention, check the carotid one and accordingly check whether there is a carotid stenosis. Stenosis we have seen earlier, coronary artery stenosis, if you remember, in atherosclerosis and in myocardial infarction or angina. So stenosis, anybody knows what is stenosis? Okay, you just revise it and then come back. Okay. Now this will give the stenosis is blood vessel narrowing, fine. Not only narrowing, but okay, in addition to narrowing, something more happens. Go through it, okay. Then these are things which is there. Then if it is shows that stenosis is less than 70 to 99%, then that means that the person can be treated on that tablets, etc. Same thing like blood pressure, whatsoever signs, symptoms are there, whatsoever we can say risk factors are there, maybe blood pressure, cholesterol, etc., etc. All are the atherosclerosis risk factors, whatsoever are there. You treat them by various ways, by drugs, by diet, by exercise, whatsoever means are there. You treat all these factors of atherosclerosis is, and if it is more than 70 to 99%, then that means that you have to go for carotid endarterectomy. that is you have to remove that clot, or you have to go for angioplasty and stenting. As I told you that here also we are going for angioplasty and stenting. Only thing, it should be that artery should not be very deep. If it is deep, then stent may not reach up to that area. So this is how transient ischemic attack. This is transient. If it is higher one, we shall have a different algorithm again. Okay. So this is how we are having the treatment. So we have seen that we are going for this FAST is one of the diagnostic tool. Then we have got this Rosier as one of the scale. What is that? Recognition of stroke. In that we are asking for some questions, whether there was any loss of consciousness or syncope, that is whether the person got unconscious. Then if it is yes, then give -1 mark. Whether there was any seizure, you know, just recently we have finished anti-epileptic drugs, you know, seizure. So whether there was any seizure, if yes, give -1 mark. Whether there is any asymmetric facial weakness, the face at one side drooping down, one side it is normal, one side muscles are too relaxed, and therefore the lips are getting towards downside because of that. Whether there is a hand weakness, asymmetric means one side it is not working properly, to what we call it as a paralysis, like, okay. So asymmetric facial weakness, asymmetric hand weakness, asymmetric leg weakness, these all three are the parameter related to paralysis. Again, speech disturbances, visual field disturbances, these are also sign of paralysis. So whatsoever are there, accordingly give them marks, and if the total score is greater than 0, then the score is, if it is greater than 0, then chances of stroke are there. But if the total score is -2, -1 or 0, stroke is unlikely, but still it is better to go for the further diagnosis, or we call it as a differential diagnosis. Again, very clearly indicated that check about hypoglycemia, because hypoglycemia can show similar signs. And if you feel that there was an hypoglycemia, then the hypoglycemia should be treated, because most of this type of signs can be because of hypoglycemia. Another score is ABCD score, ABCD2 score rather. So A for age. So age is above 60 years, then you give 1 point for that. If there is a blood pressure more than 140/80, that is hypertension, give 1 point. If clinical or neurological deficiency is there, that means these activities are there. That is 2 points for hemiparesis, that is one side is not working properly, give 2 points. 1 point for speech problem without weakness, so you add these points. Then D for duration, if it is for more than 60 minutes, give 2 points. If it is less than 60 minutes, more than 10 minutes, give 1 point. And already patient is having diabetes, then give 1 point. So this covers all various risk points, and if the risk points are there, then the maximal score is 7. But if it is, we have seen in earlier this algorithm, that if it is more than 4 and less than 4, we have made two things. I'll just show you back again. So we have seen here, that is, if ABCD2 score is less than 4 and ABCD score is more than 4. So what are the condition in that? So immediately, in both cases aspirins are there, but here the patient is immediately admitted to the this ICU, and all the investigations are done for that. Okay. So these are the importance of ABCD2 score. The patients who had suspected transient ischemic attack and who were at lower risk of stroke, that is ABCD2 score of 3 or below, should have aspirin 300 mg daily started immediately. Specialist assessment or investigation as soon as possible, but definitely within 1 week of the onset of action. Measures for secondary prevention introduced as soon as the diagnosis is confirmed, including discussion of the individual risk. People who have had transient ischemic attacks but who present late, that is more than 1 week of their last symptom resolve, should be treated as though they are at lower risk of stroke. So these are how we are going for stroke treatment. Again, if you see this aspirin here, we have seen same aspirin during cardiovascular problems also. Whenever we have seen any kind of ischemic condition in heart, aspirin is one of the treatment we have seen. Therefore, I am repeating this, that you please go through it. People who have suspected transient ischemic attack, they are at high risk of stroke, particularly who are having ABCD2 score of greater than 4 or equal to 4, and they should have aspirin 300 milligram daily. It will be started immediately. Specialist assessment and investigation should be done within 24 hours of the onset of symptoms. Then measures for secondary prevention should be introduced as soon as the diagnosis is confirmed. Include the discussion of individual risk. TIs with the score of 5 or greater to be admitted for immediate the various intervention and treatments. So interventions means just like I told you, angioplasty, etc., whatsoever it may be, and treatment within 24 hours, and patient should be admitted. So these are the importance of these scores, how these scores will be guiding us for various treatments. Then we have seen that when the score was high, then what we are going to do, that is when the carotid endoarterectomy is there. So if that particular artery is removed, that portion is removed, when 50% or higher stenosis is there, the number of patients needed to undergo surgery to prevent one ipsilateral stroke. Ipsi means one-sided. So and both side is a contralateral. Stroke in 5 years was 9 for men versus 36 for women. That is, these are the 9 men, 5 for the age 75 years of older, 18 for younger than 65 years old, 5 for those randomized within 2 weeks after their last ischemic events versus 125 for the patients randomized after more than 12 weeks. So this was on the basis that because if it is the person is very older one, so nobody will take risk for that, and in younger it is preferred to go for surgery. The benefit from surgery was the greatest in men, patient age 75 years or older, and those randomized within 2 weeks of their last ischemic events and fail rapidly with the increasing delay. These are the outcomes of these various studies. So these are various trials they are showing, that is 2 important trials are there, that is European carotid surgery trial, that is ECST, and North American symptomatic carotid endarterectomy trial. So these are the various surgery trials, so that much portion where the stenosis is there, that is removed, and then because of that either new artery is fixed to that, or that after removal of that much particularly stenosis portion, again the artery is rejoined to the, or it is reconnected. So this is how this arterectomy, that is removal of artery, has helped whenever it is there. Now stroke, we shall see what are the various algorithms. Again it is a suspected stroke. We have again done what we have excluded hypoglycemia, and we think that it is mimicking the stroke like situations. We have checked about FAST, that is face arm speech test. We have screened it. It was negative, but still there are chances of stroke. We can go for further diagnosis, consider the alternative diagnosis, what it can be, because similar signs wherever it is there, go for that, check these signs. Maybe brain tumors can be there, maybe brain infections can be there, various encephalopathies can be there, go for this kind of treatment. Establish this diagnosis rapidly, go for Rosier, just like we have seen. Okay. Then there is recognition of stroke in emergency room. Then go for NIHSS score, and check this score, assessment for immediate brain scanning, and go for MRI. Now these are all diagnostic tools, scales, then various sign symptoms, that is fast, etc. Then this MRI is one of the important sign symptom. So go for it. Immediate brain scan, if it is there, you should try to make it as fast as possible. Once it is diagnosed that there is a sort of within 24 hours, if we have done it, and if you find that there is some clot at some places, go for the treatment of RTPA. What is RTPA? Okay, you go through this. What is RTPA? Very good, Rima. So go for treatment with RTPA. Within 3 hours, check out. Go for intravenous injections. If it is okay, fine. Refer for interventional neuroradiology. Check about it. Check the outcome. If you cannot give RTPS, then admit to stroke unit for specialist care, and go for the further activity. Go in, admit in ICU stroke pathway, and go for various measures as per the protocol of that ICU treatment. So this is how stroke algorithm is there. Now what acute care we are going to do for that? So as per the Cochrane database of systemic reviews, organized patient stroke unit care. For stroke, organized stroke unit care is the form of the care provided in hospital by nurses, doctors and therapists who specialize in looking after stroke patient and work as a coordinated team. So various trials shows that patients who receive the care are more likely to survive their stroke, return to home and become independent in looking after themselves. And variety of different type of stroke unit has been developed. So this stroke becomes specialist unit, so that they are, everybody is expert in understanding the situation, understanding the sign symptoms, understanding the complications, and accordingly the best treatment they are aware about. So this is a typical, just like we have got cardiovascular disease hospitals, especially for heart attacks or angina like that. Similarly, these are the specialized stroke centers. The best result appears to come in from those who are based in the dedicated ward. So these are the dedicated wards or dedicated services are there for stroke. Now, what are these RTPAs we have seen just now? So we have to give the IV infusion. Who are the eligible? Treatment once there is a symptom, once it has been diagnosed, symptom means the first symptoms is there, you have found, and immediately if it is scanned, MRI is there, then within 3 hours go for intravenous infusion. Check out whether there is intracranial bleeding. Can you give if there is intracranial bleeding? Age should be less than 80 years, because beyond 80 years it may not be doing a good job. Early major infarctions are excluded, that is parenchyma, hypoattenuation or brain swelling greater than 1/3 of the mid-cerebral artery territory. That is, mid-cerebral artery is, I told you, it is an important artery when we have seen the figures of ischemia and hemorrhage. So if it is causing swelling of 1/3 of this territory of mid-cerebral artery, the NIHS score is less than 22, MRS is having greater than 2. These scores are there on various parameters. Then blood pressure is less than 185 by 110. The patient is not on warfarin or heparin. Platelets or anticoagulant treatment, coagulation is normal. Treatment should be given by a specialty trained physician. Facility should have be there for close monitoring of these patients. So this is how we are going for RTPA administration when we see all these conditions, and then we go for it. For stroke units, every hospital should have a stroke unit, particularly multi-specialty, multidisciplinary hospital should have. It should be managed by a multidisciplinary stroke team. Efficient referral and rehabilitation should be there, which is established for the success of stroke unit. Stroke units should significantly reduce death dependency, that is, if the person is survived and the damage is very high, then it will remain bedridden or paralyzed like that. So if the functions if the treatment is good, then there will be minimal dependency. Institutionalization means admission to the hospital and length of hospital stay, you can reduce it. So these are all the beneficial impacts, beneficial effects of the good treatment. When we are going for surgery, we have seen that we can go for surgery if required. Again, we have got two types of stroke. We have got ischemic stroke or hemorrhagic stroke. We have seen ischemic are around 85%, hemorrhagic are 15%. Now, what happens is, whenever there is ischemic stroke or hemorrhagic stroke, I'll suggest you again to read particularly myocardial infarction in vein, and one term is there, we call it as a reperfusion injury. So that is again applicable over here. So when there was a ischemic stroke or hemorrhagic stroke, in both cases what will happen is, when there is hemorrhage, then the blood will be going out of from the blood vessels, and it will not be supplied to the areas subsequent to the artery leak site, from where the artery leakage is there, and because of that there will be inflammation, there will be ischemia, and ischemia will result into inflammation. Similarly, same thing will happen to ischemia, and ischemia will cause inflammation. Now if the area is big, then inflammation will be big. If the inflammation is big, then what is difference with other tissue and brain is from all sides covered with a bony mass, that is skull, and it is beneath the skull the brain is there. Now when there is a brain is getting inflamed, then the problem is brain does not have any space to grow. Suppose we many times see that there is a inflammation on maybe hand, leg, or other areas. So whenever there is inflammation, then we feel that we understand, we can see that there is a swelling in that area. Now here also in brain also, because of that ischemic injury, there will be inflammation. Inflammation will cause the swelling, and this swelling does not have any place, so it will cause compression of brain against skull. So this compression against skull can itself more dangerous, it can be more damaging in these people. So in that people, the surgery has to be done, that is called as a decompression surgery. Here nothing big is done, only thing is skull is opened, so that the space is made available for brain to get inflamed. So this inflammation is allowed, so that that because of the skull, that compression was going on. You can imagine now that there is a internal swelling. Suppose you try with your two fists, okay. What you do is, suppose your one fist you are covering, one fist you are totally closing, and with other hand, other palm you are stopping it. Now if it is inflaming, then what will happen is, and if this outer one is very strong, it will not allow, then it will cause pressure inside, and this pressure inside is damaging. It will cause more damage to brain, because it does not have area to swell. So this swelling is allowed by just opening skull, and that is called as a decompression surgery. So whenever it is there, then if at all there is required, if doctor feel that yes, there is a inflammation is increasing, go for that, immediately go for surgery. Then that is called as a craniectomy, that is removal of skull area. Then if there with or without hydrocephalus, that is presence of watery areas accumulation in that, so go for that. indications for evacuation of hematoma, ventriculostomy or both, we go for that. Then remove that water from that, then there is no need. Then once it is there, whenever the water etc. is there, check it out, then decompress as early as possible, go for the treatment. You can have anti-inflammatory treatment also. We shall be going for that treatment, what kind of treatment we are going for, and go for this surgical intervention, remove that portion if anything is there, if it is tumorous portion is there, if any water water molecules, or what we can say, plasma is coming into that area, blood is coming to that area, to try to remove. We call it as hematomas, presence of clotted blood outside the blood vessel. So these has to be removed, and once we remove this, then check out whether possible use minimal invasive techniques. Nowadays we have got very good surgical instruments which are working on this minimal invasion, or that is smallest holes are possible, so that causes smallest injury to brain, and thus we can protect, we can do it. So these are activities. Then everything is there. If it is done, then after that you can correct it, you can close it again, you can put it back because of that, and then go for the treatment as per the conditions. It may be go for antiplatelet, anticoagulant, etc. Whatsoever treatments are there, dietary conditions, etc. Now for hemorrhage store, what you will be doing? Okay. Where it will depend on what place it is there, whether it is present in the lobes, whether it is there in the basal ganglia, whether it is there in the cerebral area, and go for that, check out what are the reasons. And there are various trials people have done. There is no difference in outcome in stable patients. Surgery outcome are better than the conservative treatment in progressive neurological deteriorations. Basal ganglia hemorrhage is there, then endoscopy is done, check it out. Evacuation is better than the conservative treatment, so evacuate it, remove some of the volume from that after hemorrhage. If cerebral hemorrhage is there which causing obstructive hydrocephalus, then surgical emergency, and then go for surgery and remove that portion. So these are some of the surgery activities are there to be done. Other surgical treatments are there in intracerebral hemorrhage are spontaneous, that is person is there as per this guidelines. There is a spontaneous intracranial hemorrhage, ICH means, it is not ICH guideline here, it is intracranial hemorrhage is having less than 72 hours. Okay, then the area which is there, the diameter of that area is less than is greater than 2 centimeter, age of the patient is more than 14 years. Then go for craniotomy, that is we call it as a decussation surgery, and it was done on around 500 patients, and it shows that it was more effective when you have done this kind of surgery. So this shows that outcome was shown that the patients are getting benefited in that. So these are various criteria where their inclusion exclusion criteria are there. I will not go into more details, but basically this was a STICH trials, that is surgical treatment of intracerebral hemorrhage, STICH. So this shows the benefits out of surgery in these people. Then next is use of various agents into that is urokinase or TPA installation or aspiration into this. Okay, thrombolysis with urokinase or various RTPs, that is tissue plasminogen activators, and minimal invasive evacuations. These are various ways by which it can be done. We shall go for this in next class with more details, and go for other treatment. In the meanwhile, as I told you, 3 important assignments. Remember, those who are not there, please put them for in group. One is all the drug for atherosclerosis, all the drugs for blood clotting, their pros, cons, what are the benefits, what are the drawbacks they are having, and this knowledge, how it will impact in selection of drug. We want this on this basis, how the selections can be done. So for selecting, what are the things to be there? So this will make it, this will give us idea. Then so all the drug for clotting, all the drug for what I told you, clotting and antiplatelet, etc. Then atherosclerosis, and third one I told you very short one about what it was. So these 3 assignments I told you. Go through these all assignments. Please answer this. The third one. Okay. And then next we'll go for the major treatment for that. Today what we have seen is various classes, various types of atherosclerosis, and what are the algorithms for the treatment. So we'll go for the next class with further details. In the meanwhile, go for the basics. Okay, take care.